This conference will now be recorded.
So let's start. Welcome, dear guests and dear friends, to the online ECG course. This webinar is a common project of Mentor Medicine and Online Cardiology Club for you. My name is Sercan Okutucu. I am a cardiologist from Ankara, Turkey, and I am very happy to see you on the screen. So firstly, I would like to thank to all of you. There are actually near 200 registrations from 40 different countries to this ECG webinar, and I am sure they will attend during the course. And I hope you will enjoy and increase your knowledge in ECG. So before we start, I would like to give some information about this platform. And on the right side, there are participant lists. We can see the name of participants. So after we introduce ourselves, we will be happy to read your name from that participant list in alphabetical order, and then you will shortly present yourself. And on the middle part on the right, there is chat box. You can write your questions or your comments in any time during the presentation. And in every presentation, there will be a digital moderator. He or she will read the questions or comments and ask to the presenter during the presentation or after the presentation. And here on the right side, we can see the settings button. So there are two persons who have really special role in this project. Without them, this project wouldn't be possible. Thanks a lot to Chietza and Israel. So I would like that they introduce themselves and concept of mentor medicine briefly to our participants.
Okay, hi everyone. My name is Chietza and I'm from Zimbabwe. I studied outside the continent, and basically I started mentor medicine with my friend Israel, who is the co-founder of Mentor Medicine, because we just wanted to give Africans the platform to grow. So we have a team that includes Zimbabweans, Rwandans, and Tswanas. And we're just giving people, Africans, the platform to grow. And we do it through our website, through our social medias, through our workshops, and through seminars like this one. In the future, we're starting an elective program here in Africa, and hopefully all of you will get to be a part of the elective program. So that's just a bit about Mentor Medicine. You can find us online, on our website, and on the social medias.
Thank you very much, Chietza. Now I will show our flyer, and I would like that our presenter will introduce themselves. Now I will open the flyer. I already introduced myself. I am Sercan Okutucu from Ankara, Turkey, and I would like that Dinaldo Oliveira present himself to us.
Good morning. I am Dinaldo Oliveira, cardiologist specialized in interventional cardiologist. I'm from Recife, Brazil.
Thank you very much, Dinaldo. And Ümit Yaşar Sinan.
Hi, this is Ümit Yaşar Sinan. I'm working in Istanbul University Cerrahpaşa Institute of Cardiology from Istanbul, Turkey. Hello, everyone, and it's a great pleasure for me to take in part in this project. Thank you.
Thank you very much. Alper Karakuş.
Yeah, hi, everybody. Have a good day to all. My name is Alper. I'm from Ankara, also Ankara, Turkey. Sorry, Adıyaman, Turkey. I'm very happy to be a part of this project, and this project shows us that we all need together. So I think we are going to enjoy. We will see each other in the next week. My session is going to be in next Sunday. I'm very happy to this, very excited to this. So thank you, Dr. Sercan, again.
You're welcome. And I will introduce Begüm Yetiş Sayan. She couldn't attend to this session, but she will attend, and she will show us the interesting ECG. She's working in Ankara, Turkey. And Cengiz Şabanoğlu, can you present yourself, please?
Yeah, hi everyone. I'm Cengiz Şabanoğlu, cardiology specialist in Turkey, practicing in interventional cardiology. I'm also feel very lucky to be a part of this great team. I wish this good project will succeed. Hi everyone, and good luck.
Thank you. And Kader Elis.
Hi everyone, I am Kader Uzay from Turkey. I'm a cardiologist also. I thank you, Mentor Medicine and Online Cardiology Club, for the opportunity you offered me, and I'm very glad to be here with you. We will talk about the effects of electrolyte imbalances and some important drugs on ECG next week. I tried to make my best. See you.
Thank you very much, Kader. And Özge, can you present yourself?
Hi everyone, this is Özge. I am cardiologist in Ankara in Turkey. I am very glad to be with you in this project. I wish everyone a good ECG webinar.
Thank you very much. And let's check our program briefly, because I think you already had this in your email, but it's better to overview this program. So today, after the introduction, we will start with the fundamentals of the ECG. I will be the speaker, and Professor Dinaldo Oliveira will be the digital moderator. He will review the questions and ask to me, and then he will present the normal rhythm and arrhythmia, and I will be the digital moderator, and then we will have the questions and answer, and our today's program will finish. And tomorrow we will start at 10 at Central European time. Dr. Ümit Yaşar Sinan will do presentation entitled ECG in conduction disturbances, and I will be the moderator. And then Cengiz Şabanoğlu will present the ECG in cardiac chamber enlargement, and Ümit Yaşar will be the digital moderator. And after this week, next week, in 11th July, Özge will present us ECG in coronary artery disease, and then Kader Eliz will present us ECG in electrolyte abnormalities and drug effects. And in our final day, Alper Karakuş will show us the interesting ECGs, eponymous ECGs, and Begüm Sayın will show us the some interesting ECG cases, and we will evaluate these cases with her. So now I will stop my screen sharing, and yes, you are here. Can you read the participants on the right side, and they will introduce themselves briefly, because we have time before start, and then after everyone knows each other, then we can start our presentation.
So we will start with Yakub. I hope I've said that right.
Let's start with A, the letter A.
Okay, let's see how this is.
On participant list.
Okay. Okay, great. So it looks like we're going to start with Ali.
Hello everyone, I am Ali. I'm general physician. Graduated from Azerbaijan Medical University. Thank you for this presentation.
We're happy to have you. Next we have Carol Gomez. Is Carol here?
Carol is my daughter. I'm sorry, because I'm using her computer. I explained it in the beginning. I'm not Carol, I'm Dinaldo.
Oh yeah. Then we have Chido.
Hey everyone, I'm Chido Chashi. I am in Zimbabwe right now, but I'm a medical student at Dalian Medical University in China.
Okay, thanks Chido. Dennis?
Hello everyone, my name is Dennis, medical student from Zimbabwe.
Okay, thanks Dennis. Gilbert?
Hello everyone, it's so nice to meet you all in this part of the webinar. I hope to learn a lot from this first part of the webinar. Thank you all.
Okay, thanks Gilbert.
Cihetsa, we passed the Duygu Ara.
Okay.
Hi everyone, I am Duygu. I am from Ankara and I study Afya medical student. I excited this meeting. Thanks very much.
Okay, thanks Duygu. Israel?
Yes, hi everybody. I'm Israel from Rwanda. I'm a medical student at Dalian Medical University. I'm happy to be with you. Thank you.
Okay, Israel is also part of our mental medicine team. Then we have Lee.
Hi everyone. My name is Lee. I'm working in intensive care unit and CCU in a private hospital in Malaysia.
Thanks so much, Lee. Magdalene.
Hi, I'm Magdalene. I'm from Malaysia. I'm a medical student.
Oh, happy to have you, Magdalene. Maria.
Hello everyone, I'm Maria. I'm from Uganda and recently finished my studies in Dalian Medical University.
Thanks, Maria. Then we have Mary Ban.
Hi for everyone. I'm cardiologist from Azerbaijan, Baku. It's really joyful and fascinating to meet with you on this ECG webinar. Thank you.
Thank you, Dr. Mirban. Dr. Musonda?
Hi, I'm Dr. Mzonda, first year registrar and internal medicine, Livingstone, Zambia.
Welcome, Dr. Musonda. Naja?
Hi, Chesa.
Hey,
I hope you're
Naja,
doing
can you
good.
introduce yourself?
Yes, I hope you're doing good. It's long time, right? I'm
Long
Najahat.
time.
I'm Najahat from Maldives. I'm a medical intern.
Thanks so much, Naja. Nokuzola.
Hi guys, Nogozola Nicole from Zimbabwe. I just graduated from Vinitsa Medical University in Ukraine.
Oh, congratulations.
Thank
Then
you.
we have
Thank you very much.
Then we have Ogjan.
Yes, hi everyone. I'm Oğuzhan Ateş and I'm from Turkey, Konya. I'm studying at Selçuk University Faculty of Medicine at third year, and I'm very happy to be here in this education with you.
We're happy to have you. Shamini from Malaysia.
Hi everyone, I'm Shamini from Malaysia. I'm an ICU and CCU nurse.
Happy to have you. Dr.
Thank
Shandirai.
you.
Hi everyone, I'm Dr. Shandirai from Zimbabwe.
Happy to have you. Somvelo Anita.
Hi everyone, I'm Somvelo. I'm from Zimbabwe. I graduated last week from Vinitsa in Ukraine.
Oh, congratulations.
Thank you.
Same school with Nokuzola?
Yes, we're together.
Oh, that's nice. Nurse Stephanie.
Hello everyone, I'm Stephanie Tan from the Philippines and I'm a medical student.
Oh, okay, medical student. Sorry, Stephanie. Happy to have you. Tugba.
Hello everyone, I'm from Turkey and I've just begun my residency in radiation oncology. And thank you for this webinar.
Thank you for joining us. Umit Yasa.
Hi again. I have already introduced myself. My name is Dr. Mitesh Arslan from Istanbul, Turkey. I'm a adult cardiologist, and the microphone can go another one, I think.
Okay. Dr. Felician from Rwanda.
Yeah, hello everyone. Yes, hello everyone. My name is Wes Garcia, and I'm a medical student. So I'm glad to be here. Thank you for this ECG webinar.
Thanks for joining us. Valerie Tan.
Hello everyone, nice to meet you. Guys, I'm a medical student from Malaysia.
Happy to have you. Enoch Williams.
Hi everyone, I'm Waswa Enoch Williams. I'm a medical student from Uganda. It's a pleasure to be here.
Happy to have you. Wendy Kamara.
Good day, everyone. I'm Wendy Kamara from Philippines, and I'm really interested in cardiology. That's why I joined this webinar. Thank you.
Thanks for joining us. Dr. Witness Mapanga.
Hello, everyone. I'm working in South Africa as an oncologist. It's good to be here. Thank you.
We're happy to have you. And the last person we have is Yakub.
Hello, greetings everyone. My name is Yakub. I'm from Bahrain. I'm a fifth-year medical student. It's my pleasure to be part of this webinar, and I hope that we learn a lot of stuff in this webinar.
Perfect, thanks. So that's everyone. So I'll just hand it back to Dr. Sercan, who will be presenting soon.
Yeah, thanks, Chietza. Can you see my screen?
We can.
Perfect. Yeah. So welcome, dear friends, again. In the following next 30 minutes, I will present the fundamentals of the ECG. This presentation will be more practical, but we will also talk about some pathophysiological points of the ECG. And so let's start with what is ECG. ECG is the process of recording the electrical activity of the heart over a time by using electrodes placed over the skin. And here we can see on the lower part of the slide a doodle of the Google, and the person in that doodle is Wilhelm Einthoven. He invented the ECG more than 100 years ago, and it was like a big device, as you can see. And here on the right side we can see the modern device, and he had the Nobel Prize in 1924 with that invention. And more or less the devices are the same. Basically it has three parts: the electrodes, connection and transmission system, and the signal amplifier. So let's look at the electrical activity of the heart. This is a very simplistic presentation of electrical activity. As you know, the resting membrane potential of the myocardium is mainly negative, and mainly the potassium ions inside of the cell and the sodium ions outside of the cell, and so it is negatively charged. And when the depolarization wave comes, there are ion fluxes and there will be electrical activity. And according to the reference electrodes and the exploring electrodes, we will have a deflection, and which represent the depolarization. And then there will be a repolarization, and there will be another vector, so we will record that deflection too. But before entering more details, let's look to three principles. The first, the myocardium is depolarized from endocardium to epicardium. This is the first rule. And of course, every cell of myocardium has different electrical property. For example, if it is a pacemaker tissue, it has different action potential. If it is a myocardium, it has different action potential. It can change from atrium to ventricle, and from endocardial cell to epicardial cell. As we can see, endocardial cell has a bigger, longer action potential, and the epicardial cell has a more shorter action potential. And because of that, the depolarization starts from endocardium to epicardium, but repolarization will start from epicardium to endocardium. And this is very important also for mechanistic working of the heart. And let's look to the exploring electrode and reference electrode concepts. Here we can see on upper part, the vector of the heart is going towards the exploring electrode. So this will cause the positive deflection in ECG. However, if the vector is going away from the exploring electrode, in this time it will cause the negative deflection in the ECG. And then before entering into details, let's look to the ECG paper. Here we can see a typical ECG paper. On the horizontal axis, we can see the time, and on the vertical axis, there is amplitude. And here we can see the large squares and the little squares. Here I will show with laser pointer, and this is the small square, and these 5 are the large square. So each small square is 40 milliseconds, and each big square is 200 milliseconds. So the printing rate of the horizontal axis is called sweeping rate, and it should be 25 millimeter per second. And here we can see the vertical axis. This is amplitude axis. So this is the calibration signal. This calibration signal should be 10 millimeter or 10 little square. 1, 2, 3, and 5 here, 8, 9, 10 little squares. So 10 millimeter should be 1 millivolt. So we should check these calibration signals and sweeping rates in all ECG. And let's look at typical ECG. This is a typical normal ECG. And what we see here is that there are 12 leads. There are lead 1, 2, 3, AVR, AVL, AVF, and the 6 precordial leads starting from V1 to V6. And usually in every ECG, there is a rhythm strip on below, and this is usually selected from D2, and in some devices they choose the V5. And let's look to the extremity leads. There are 3 bipolar and 3 unipolar extremity leads. These are 3 bipolar leads. D1, lead 1, lead 2, and lead 3 are 3 bipolar leads, and there are 3 unipolar augmented leads, namely AVL, AVF, and AVR. And for better understanding this, we should know the Einthoven's triangle. I am sure every one of you heard about this. This is typical Einthoven triangle. We can see that the D1 is recording activity from right arm to left arm, and from left arm to left leg is D3, and from right arm to left leg is D2. As we can remember from our physics lectures, if we add D1 to D3, then we can see we will have the D2 vector. So the same principle is working in here. And on the below, we can see 3 leads more. These are unipolar augmented leads. In this one, there is 1 reference electrode and 1 exploring electrode. The reference electrode is Wilson central terminal. And the exploring electrode in here, if it is left foot, then it will be AVF. If it is left arm, then it will be AVL. And if it is right arm, then it will be AVR. A stands for augmented, so it will amplify the signal. And we have 6 precordial leads, namely from V1 to V6. And here we can see that the proper localizations of them is really important, because each of us can localize these electrodes for extremities easily, because it is easy to put them to our limbs, to the arms. But for the chest is really critical. We should put the correct place to have the better ECG. So we should put the V1 to the 4th intercostal space on the right side of the sternum, and V2 on the left side of the sternum and the 4th intercostal space. And we should put the V4 to the intersection of mid-clavicular line to the 5th intercostal space, and we should put V3 to midway between V2 and V4, and we should put V5 to anterior axillary line at the same level with V4, and we should put V6 to the mid-axillary line at the same level with V4. And let's see this in a better figure. So as we all know, this part is manubrium sterni, and at that part there is second rib, and this should be the 2nd intercostal space, 3rd intercostal space, and 4th intercostal space. 4th intercostal space, on the right side we will put the V1, and the left side V2 and V4 here, and midway between them is V3, and here we should put the anterior axillary line in the same level V5, and mid axillary line at the same level V6. Yeah, and this is interesting because it's easy to do this in a slim person, and or especially for the male. But for female, we can do some mistakes, because we usually put these electrodes below the breast, and it's not the place that we want to put. Because let's see from here, they put this is actually a wrong placement. They put the V1, V2, as you see, to the second intercostal space. They should put there, and just below the breast, it's near 7 or 8 intercostal space. So we should sometimes need to put on the breast to have the exact localization. So we should be careful about this. And these are the other leads that we can use sometimes in clinical practice. The Dr. Özge will talk about the coronary artery disease and myocardial infarction. And especially for posterior myocardial infarction, we need to have the posterior leads, V7, V8, and V9 for detection of posterior MI. And so for V7, we should put the same level with V4 to posterior axillary line. And for V8, we should put the mid-scapular line with the same level with V4. And for the V9, we should put the left paraspinal line with the same level with the V4. So then we will have the posterior leads. And sometimes in dextrocardia and sometimes for right ventricular myocardial infarction, we need to have the right ventricular leads. So V1 and V2 should stay exactly at the same place. Then we need to put the V3, V4, V5 as symmetrical for the left placement. So then we will have the right ventricular leads. And especially for right ventricular MI, the V4R is very important. And just some information about this Lewis lead. Just remember that the Lewis lead is something that we modify a little bit the electrodes, and we will have the better image for the, or better recording for the P wave. If we are not sure about is there any P wave or not, if you want to evaluate the P wave, then we can look the Lewis lead. And there is another special circumstance. Dr. Alper will talk about the eponymous ECG, and among the eponymous ECGs, one of the famous thing is Brugada syndrome. So here on the right side, we can see the sail pattern. So sometimes for having sail pattern, we need to put our electrodes 2 intercostal space above. So we should have the recording from second intercostal space. So then here you can see we will have better sail pattern and we can analyze better. Yeah. So these are the standard 12 leads of ECG. We have the 6 extremity leads on the frontal plane, and we have the 6 precordial leads on the horizontal plane. The lead 1 and AVL is given information about the lateral and high lateral part, and D2, D3, and AVF give information about inferior wall, and V1, V2 the septal and somehow anterior, V3, V4 anterior, and V5 and V6 the lateral part. And let's look at how ECG waves are generated. This part is the sinoatrial node. It generates the activity between 60 to 100, and this activity is transmitted to AV node via atria. And then at that time, we will have the atrial depolarization. So we will have the P wave in here. Then the conduction will slow until the Purkinje system. And then we will have the PR segment here. This is important to understand. PR interval is different from the PR segment. PR interval starts from the onset of P wave to onset of QRS complex. This is PR interval. But PR segments start with the end of P wave to onset of QRS. This is PR segment. PR interval. If PR interval prolonged, what we will have is, especially we see this in the AV block. If the PR interval is short, we have this especially some tachycardia and some accessory pathways. And the PR segment is especially important in pericarditis. After the Purkinje system, then we will have the ventricular depolarization. This is a multiphasic depolarization process. We will have the first vector from left to right from the septum. Then we will have the predominantly left second vector, and we will have another third vector. This especially posterolateral part of the ventricle will be depolarized later. And then we will have the ventricular repolarization. Then we will have the T wave. So if you ask when atrium is repolarized in here usually, and the atrial repolarization wave is usually buried into QRS complex. Yeah, here we can see the waves better in a simple way. We talk about the P wave, this atrial depolarization, and PR interval, PR segment. QRS complex is ventricular depolarization. And here is another important concept, QT interval. QT interval is starting from the Q wave to end of the T wave. This is especially important nowadays because we gave a lot the kinidins, the hydroxychloroquines, and the macrolides in the COVID-19 pandemic in early phases. So then we need to use the QT interval frequently. So we will talk about the QT interval in details. And after QRS complex, this Q is the first negative wave in the QRS complex. R is the first positive wave in the QRS complex. And S is the second negative wave in QRS complex. If we have another positive wave in this complex, then it's called as R prime. And if we have one more positive wave in this QRS complex, then it's called as R bis. And after the end of the S wave, we have J point. This is J point. This is especially important some repolarization abnormalities, and also there is a special wave called Osborn wave. We have a prominent J wave, and it's also one thing that we should remember, the J wave here. And there is ST segment. This ST segment is especially important in coronary artery disease. The Dr. Özge will talk this in details, and QT interval is especially important about the drug effects and electrolyte abnormalities, and Dr. Kader Eliz will talk about this in details. And this is the T wave, is ventricular repolarization wave. And here we can see this again. Let's look about some important numbers. The P wave duration is important. Dr. Cengiz will talk about the chamber enlargement. In the chamber enlargement, the P wave duration will increase. So P wave should be less than 3 Liddell squares, 120 milliseconds. And the amplitude should be less than 2.5 millimeter. And Q wave should be less than 40 milliseconds, and its amplitude should be less than 1/4 of the R wave. If it is wider and the amplitude is high, then it will be pathological Q wave, and it will be a one sign of infarct, and Dr. Özge will talk about this in details. And QRS complex should be less than 120 milliseconds. We will talk it in conduction disturbances in details. And T wave should be less than 2/3 of R wave. And what are the limits? In the limb derivations, it should be less than 6 millimeter, and in precordial, it should be less than 10 millimeter. And PR interval should be between 120 millisecond to 200 millisecond. If it is above this, then it's called as first degree AV block, as we told before. Of course, this corrected QT interval can change. It should be smaller than 470 in female, and it should be smaller than 450 in male. Here. And let's look at another concept. Here I want to show that the P wave has two components. The first component is right atrial component, and the second component is left atrial component. So if the rhythm is sinus, we should always have the positive P wave in D2. And the first part, as we can see, the right atrial part, and the second part is left atrial part. If there is bifid P wave, the Dr. Cengiz will talk about this on tomorrow, and we will learn more things about this. And the thing about the precordial leads, V1 should be here. The first vector will be oriented to V1, so we will have positive deflection in here as a right atrial activity. Then we will have a negative deflection, because if V1 is here, this vector is going to there, so we will have the negative deflection. So this typical pattern that we will have in V1. Yeah, this is a little bit more complicated. This is ventricular depolarization process, is a multiphasic process. So when the activity come to here, the first vector will be from left to right in the septum. Then think about this V1. We will have a positive deflection with the first vector, and the second vector will orient to the left because the left myocardium is bigger than the right. Then we will have a negative deflection in V1, and just opposite in the V5 or V6, we will have a negative deflection because of the first vector, and we will have a positive deflection, and third vector will make a little S wave in here. Yeah. Let's give an example about this calculation of corrected QT interval. As we told before, we should measure the QT interval from the onset of Q wave to end of T wave. Then we will have QT interval. But for correction, let's look the two examples on the right side. The above is normal corrected QT interval. So we should count the QT interval from here, the onset of the QRS complex to the end of T wave, which is around 0.40 seconds. So we should write this as a second. So we write this on above, and we should calculate the RR interval also as a second, 0.84. So we should take the root square of this, and when we calculate, it's 0.40 second or 430 millisecond. It's normal. And let's look to below. From the onset of Q wave to the end of T wave is around 0.52 second. Here we just multiply 13 little square with 0.04 second, and we will have this. And then we calculate the RR interval, and we take the root square of this, and then our corrected QT interval is 530 millisecond, which is really prolonged. Actually, these things are written on the above the ECG. Of course, we should confirm that they are correct or not, but they are usually written above. But as a rule of thumb, we can easily have idea about this by one simple method. The QT interval should be less than half of RR interval. Let's look to this one, and if we think about the half, it should be here, and here you can see it's prolonged more than the half of the RR interval. So then we can tell that, okay, the QT interval is prolonged. Of course, for the exact value, we should measure. Yes, this is another concept, cardiac axis. This is the normal cardiac axis. We are talking about ventricular depolarization axis. And of course, we can calculate the axis for every wave. But when we tell the cardiac axis, it is ventricular depolarization axis, and it should be between the -30 to 90. This is normal axis. If it is above the -30, it is left axis deviation. If it is after positive 90, then it is right axis deviation. And in northwest part, it's called as extreme axis deviation. This can be either left axis deviation, or this might be right axis deviation. We can calculate the cardiac axis with some methods, like quadrant methods, 3 leads methods, and like the isoelectric methods. Now I will show the isoelectric methods. Isoelectric methods is to find in which derivation positive and negative waves are zero. So like that. So if we find this derivation, it means that our cardiac axis is perpendicular to that derivation. So let's look one example. Here, which derivation is isoelectric? Lead 1. So here is positive and here is a negative wave, so it's near to zero. So our cardiac axis should be perpendicular to this. So we know that this is the lead 1. So this is lead 1. So our cardiac axis is perpendicular to this. So cardiac axis can be in above direction or below direction. How we can understand? If it is directed to down, then AVF should be positive. Let's look. AVF is positive. Yes, it's positive. So our cardiac axis is on the way of AVF, so it is 90 degrees. And let's look another example. The AVL is isoelectric, so our cardiac axis should be perpendicular to AVL. And so there are two options. This is AVL. So this is perpendicular vector. So it might be in that direction, or it might be in that direction. So if it is positive in D2, then it should be on this direction. So it is positive in D2. So our cardiac axis is 60 degrees, which is normal. Yeah, here are 3 examples. Here we can see the normal axis, positive in D2, D1, and D3. And here we can see the left axis deviation. Here you can see is predominantly negative in D2 and D3. And here we can see the right axis deviation. Yeah, here we can see that D1 is negative. Yeah, this is another concept. This is a little bit confusing sometimes, but let's look at this in a simple way. Clockwise rotation or counterclockwise rotation. This is something that we can evaluate in the horizontal section. We are looking patients like they lay in CT, or we are looking from them to their feet. And usually the transition from R to S should be between V3 and V4. If this transition passes to V5 or V6, then we are, as we can see, the septum is going in that way. So it's clockwise rotation. So if this transition is like in V1 or V2, so the septum is going on the counterclockwise way. So it's counterclockwise rotation. And here are some examples. This is V1, V2, V3, V4, V5, V6, and where our S become equal in V4. So it is normal. And here at V3, it's again normal. And here in V2, here you can see RS, and then R become bigger. So at V2, so there is counterclockwise rotation. Another example of counterclockwise rotation here is. And there is the clockwise rotation. The R to S become equal, or R past the S in the V5 or V6, and another example of clockwise rotation. Yeah, and let's look at the calculation of heart rate. We can calculate the heart rate with a simple way. We can divide the number of large square to, we can divide 300 to number of big square, and we can divide the number of little square with the 1,500, then we can get the heart rate. So of course this is more precise, but I personally prefer to divide the large square. If there are 4 large square is 75, if 5, if it is 60. So this is how we calculate the heart rate. Of course it's like a simple mathematical calculation, because 1 little square is 0.04 second, 40 millisecond, then we can calculate the heart rate. So as a summary, how we can interpret the ECG. So first thing, we should check the name of the patient and date of the ECG. Then we should look that is this recording is a standard recording? What about the calibration and sweep rate? And how is the quality of recording? Are there any artifacts? Which I will show few artifacts in the following slide. And what is the rhythm? Is it sinus rhythm? Is it junctional rhythm? We will talk about in details in the next presentation about the rhythms. And we should calculate the heart rate and the cardiac axis and the waves, and we should evaluate the waves and the morphology and duration of that. And of course, the P and QRS relationship, RR interval and regularity, and PP interval and regularity. And we can also have additional comments. Let's look to these artifacts. This artifact is alternative current artifact, and this is like a motion and tremor artifact. And on the right side, we can see the isoelectric shift. And let's check this ECG. Think that the patient name is written here. It's correct. The patient name is patient, and the date is okay. And now we check the sweep rate. Sweep rate is okay. And we look the signal here, the calibration signal. Amplitude is okay. 10 little squares, 10 millimeter, 1 millivolt, and then we need to calculate the heart rate. Then here the device is written, but of course we can calculate. It's less than 4 big square. It's 18, and the rhythm is sinus. How we will understand in the following presentation we will talk about this, but the P wave is positive in D2, D3, and AVF, and it's negative in AVR. AVR has special lead. I should tell that AVR is a cavity lead. So usually the things is always different than AVR, but we can use AVR. For example, we can check the ST segment in AVR. We can check some parameters in AVR in some types of arrhythmia. So AVR is importantly. So then after this, we will check that every P waves is follow the QRS complex, and we will look the P wave morphology, PR interval, the QRS duration. And when I check all of them, this is a completely normal ECG. And let's check this in this ECG, here we can see there are more than 6 big squares. So there is a bradycardia. This patient has a heart rate is around 45, and but there are P waves positive in D2, D3, in AVF, and here in AVR is negative. So it is sinus rhythm, but sinus bradycardia. And there is a little bit ST segment change in here. We can see it's a little bit elevated. This pattern is early repolarization pattern, and little bit J point elevation is typical for early repolarization pattern. And here we can see on precordial leads, there is U wave. This is the famous U wave. We will talk about in details. The U wave is we can observe in normal patient, in bradycardia, but it is typical for hypokalemia, digitalis use, and we will talk about the U wave. There are some theories about the formation of U wave, like some telling that it is related with myocardial cells or Purkinje cells, or the latest repolarization of the ventricles. So it has some like theories about it. But here in this ECG, we encounter the U wave. So this is our ECG book. And if you wish to read this ECG book, you can scan the QR code with your phone, and you can download this book freely. I will wait 30 seconds. If you wish to scan this QR code, you will download this complimentary for you. And if you want to ask any questions about anything, you can send me email. This is my email address. Thank you very much.
Thank you, Professor Okutucu, for this very interesting and clarifying presentation. It was wonderful. Now, if you have any question, please send to us through chat. The question and answer is open. If you have any question, please send to us through chat. Professor Sercan, if anyone do not have a question, I have a question for you. Can you explain to us in single words a detail if you do not calibrate or you do not look at the speed of ECG? We have some trouble if it's happened.
Yes, of course. Sometimes they record ECG with a sweep rate of 50 millimeter per second. Then we will have the long ECG that we might think that patient have bradycardia. Usually, I should tell about this in details. When we do electrophysiology, we record this ECG with the 50 millimeter per second, and we will have the longer ECGs. We can analyze the durations better. But if like we record ECG with 50 millimeter per second, then we can think that, okay, this patient have bradycardia, or we can have the strange waves. So this is for sweep rate. And for the vertical axis, for amplitude, if we, for example, record in the like 5 millimeter per millivolt, then we can think that patient have the low voltage. And if we record with 20 millimeter per millivolt, then we can think the patient have the left ventricular hypertrophy. So these settings are really important.
If someone have a question, please send to us through chat. I have another little question for you, Professor Okutucu. If the guy change or commit a mistake and change the leads, for example, put the electrode in wrong position, it's invalidate the ECG or not?
Yeah, of course. You mean like misplacement of electrodes?
Yes, it is.
Yeah, it is really good exercise to understand the ECG. There are some patterns that if we misplace the electrodes, we will have completely different P waves, especially. Then sometimes when we look, okay, this patient have the like negative P wave in the D2. Of course, we can have this in dextrocardia, but of course it will direct us. It will like we will have wrong information. But I will show some examples. We can understand, for example, okay, if the patient have this ECG, then this, for example, right arm and the left arm is like misplaced. Or if this patient have this ECG, then the right arm and the left leg is misplaced. But it is a little bit confusing. I should show the image. I will show the image.
Okay, thanks. And not for this audience, but only as an information. Sometimes we have changed, for example, the size to analyze better. It's common in your practice. For example,
yes. Sometimes the patient have really like sometimes for analyzing better we do, and sometimes the patient have really high voltage. Then we need to make it like 5 millimeters per millivolt to to see it on the paper and calculate. And sometimes we increase the amplitude, of course.
Someone have some question to Professor Okutucu? The question is open. Well, to summarize your presentation for beginners, which is the most important advice do you have?
Yes, actually, this is the fundamental presentation. So if I need to just choose one point, we should properly locate the electrodes, because if we misplaced it, then we can have the different ECG and it's difficult to evaluate.
Okay, I want to say on behalf of this group, thanks to Professor Okutucu for this wonderful presentation. And if anyone do not have any question, we'll move on the next session.
Yeah, thank you, Dinaldo. Now I will send the screen sharing request to you. If you wish, I can open your presentation too.
If I can, it's better because I change only one detail, but if not possible, I can. Can you send me?
Yes, I already sent to you.
Thanks. I'm trying to start now. Are you seeing?
Yes, it's perfect.
Are you seeing my presentation?
Yes, yes, we can see.
Well, it's fine. Good morning, everybody. Now, from now on, I will try to share with you some concepts about basic normal rhythm and arrhythmias. There is no conflict of interest in this presentation. I can't. No, it's fine. It is our agenda for today. We try to share some concepts about silent rhythm and arrhythmias. Let's start. Which means sinus rhythm. As Professor Okutucu said, in sinus rhythm arises from sinatrial node. We should look at P wave in details. First of all, the P wave X is normal. The second, P wave is positive on D1, D2, AVR, AVF, V4, V5, V6, and negative on AVR. The normal rates is between 60 and 100, and QRS is normal. Why? Because the electricity is flowing on normal tissue. As defined during the Professor Okutucu lecture, bradycardia is when heart rate is inferior less BPM, and tachycardia when heart rate is more than 100 BPM. Here you can see an example. Look at D2, D3, and AVF. Look at P. P is positive here, here, and here. However, when you look at P on AVR, it is negative, and there is a narrow QRS, so it's called sinus rhythm. And there is a sequence which is repeated, P, QRS, T, P, QRS, T, P, QRS, T, and go on. What about escape beat? Escape beat could be junctional or ventricular. When we identify escape beat from junction origin, when P wave is buried in QRS, or if P is present, it is negative on D2, D3, and AVF, and positive on AVR. Usually narrow QRS, and the rate varies from 40 to 6 BPM. While when we have ventricular escape beat, QRS usually is more than 120 milliseconds, 0.2 seconds, or the heart rate is from 20 to 40. Here we can see an example. Look at this P wave is negative on D2, D3, and AVF, and QRS is narrow. It is a junctional rhythm. It's completely different from this one. Look here at D2, D3, and AVF. P wave is positive, and on AVR, P wave is negative. However, when you look, this is our opposite side. P wave is negative on D2, D3, and AVF, and positive on AVR. So this is a junctional rhythm. We can have a premature atrial complex as well. How to identify them? Look at P. There is P waves. However, this P waves is different from that originates from synatrial node. The QRS in this partner is less than 120 milliseconds, is normal, is narrow, and PR is more than 0.12 seconds. It's abnormal. Look at the red ellipses. You can see here one different P waves compared with the normal sinus rhythm. So, and you look at the QRS is narrow as well. So it's called premature atrial complex. Another way, how to identify premature ventricular complex. So there is no P wave before QRS because the rhythm is originated from ventricle. It means that the conduction, the QRS, is slowly. So that represents that QRS is wide, more than 120 milliseconds. By the way, if you sum the coupling interval plus compensatory pause, it means 2 times sinus cycles. Sometimes this premature ventricular complex could be monomorphic or multiform. And there are 2 important concepts here. One, first of all, is bigeminalism. What is? Every sinus beat followed by premature ventricular complex. The other concept is called trigeminalism. It means that every second sinus beats followed by premature ventricular complex. Let me go now to examples. Look at this encycle ellipse. This QRS is wide. There is no P before it. So it's called premature ventricular complexes. Now, this ECG shows us the bigeminalism. Look at that. It is sinus rhythm, sinus beat, sinus beat. However, following each sinus beat, there is a ventricular beat. So the sequence is 1 sinus rhythm, 1 ventricular rhythm, 1 sinus rhythm, 1 ventricular rhythm. It's called bigeminalism. If the sequence was 2 sinus rhythms followed by 1 ventricular complex, 2 sinus complex followed by 1 ventricular complex, it is called trigeminalism, and so on. So another rhythm is called accelerated idioventricular rhythm. In this rhythm, the stimulus originated only in the ventricle. It means that QRS is wide, more than 120 milliseconds, and the heart rate varies from 40 to 120 BPM. Let me show you here the example. When you look this ECG, there is no P identified, and there is wide QRS. In this particular example, the frequency is 75 BPM. It's called accelerated idioventricular rhythm. So, what about atrial tachycardia? Atrial tachycardia, as the name says, the rhythm originates from atria. The rate varies between 100 and 24 BPM. The main characteristic that the rhythm is regular, and there is isolectric baseline between atrial P. In this rhythm, there is P. However, the P is not originated, the same morphology for that originated from sinoatrial normal rhythm. Here you can see an example. Remember, the rate of atrial tachycardia varies between 124, and that in this arrhythmia is a regular pattern. Look at in circle ellipse. You can see here, P wave is not P wave from sinoatrial node, and between them there is an isoelectric baseline line. It's called atrial tachycardia. Another way, we have multifocal atrial tachycardia. It's originated from multiple sites from atria, which is the characteristic is irregular PP interval. To have this, we have to have 3 or more different P waves morphology, and between them, isoelectric baseline. Let me show you an example. Look at this ECG, specifically at head ellipse. Look at this complex, and this complex. If you look in details to this P, and these P waves, they are different. So this patient has multifocal atrial tachycardia because at least 3 different P's conducting the impulse. What about other kinds of supraventricular arrhythmia? In general, supraventricular arrhythmia is called when the rhythm originates from sinus node, atria, atrioventricular node, or his bundle. Let me share with you 2 most common of them. First of all, it's called AV node reentrant tachycardia, which is the characteristic on ECG. First of all, the QRS is normal unless there is aberrant conduction. The heart rate varies from 150 to 250 BPMs. It is a regular rhythm, and P can be buried in QRS, or P can be before QRS, it's called pseudo S, or P could be after QRS, it's called R. Let me show you here one example. Look at this. In this rhythm, it's regular. If you measure the RR intervals, they are regular. When we look at this morphology, we can't find P because P is buried in QRS, and this is regular. The frequency, the heart rate is almost 200. It's called AV node reentrant tachycardia. Another example of supraventricular arrhythmia is AV reentrant tachycardia called Wolff-Parkinson-White syndrome, which is the main characteristic of this rhythm, is delta wave. What is delta wave? Delta wave is a slender and broad upstroke QRS. In this arrhythmia, the heart rate varies 150 to 250. PR interval is shorter than normal. So we have a shorter PR interval with delta wave. Usually QRS is wide, and it can be CT-T wave change. Let me show you in detail. We can see here the low line is normal ECG, and the higher line is abnormal with P wave. If you look at here, you can see here the slender and broad upstroke QRS is called delta wave. You can see here the shorter PR interval. It means less than 0.12 seconds. If you measure in total, QRS is wide, and sometimes there is change in CT-T wave. It's a hallmark of Wolff-Parkinson-White syndrome. It's called delta wave with shorter PR interval. If you look at this example, it is Wolff-Parkinson-White syndrome ECG. Look at in cycle ellipse. You can see here the short PR, and you can see here delta wave. So here we establish the diagnosis of Wolff-Parkinson-White syndrome. Another arrhythmia common is called atrial flutter. So how can identify atrial flutter on ECG? We should looking for recurring, regular, sawtooth flutter waves plus lack of isoelectrical activity between F waves. The atrial rate varies between 150 and 350, and the hallmark is flutter waves, uppercase F waves is called. It's classified as type 1 and type 2. When F waves is negative on D3, D2, and AVF, it's called type 1. And when flutter waves is positive on D2, D3, and AVF, it's called type 2. What about the ventricular response? This depends on the action, electroactivity of AV node. It can be blocked 2 by 1. It means 150 of ventricular response. If this block is 3 by 1, it means 100. If this block is 4 by 1, it means 75, and go on. Here, you can see clearly F uppercase waves. You can see here is a hallmark of atrial flutter. In this specific particular case, F wave is negative on D2, D3, and AVF. So it's called type 1 atrial flutter. What about atrial fibrillation? Atrial fibrillation is a so important arrhythmia because sometimes the first clinical manifestation is a stroke, which characterize atrial fibrillation. Low case low case F wave. The rate varies from 300 to 600. There is low amplitude oscillation and irregular RR interval. Here, I should emphasize that this arrhythmia is the most irregular arrhythmia existent. So, if you take your stethoscope, put on patient chest, and listen to them without any kind of partner, based on physical examination, you should imagine that this patient has atrial fibrillation. Sercan is smiling because he knows that every clinical cardiologist, when listen to atrial fibrillation from physical examination, already identify before ECG in the majority of cases. Here you can see an example. Look at F waves, low case F waves, low amplitude, and look at the RR intervals, completely irregular. As an example, I'm showing here the sinus rhythm. Look at PQRST, PQRST, it's sinus. However, when we look below, look at there is no P wave identified and there is completely irregular ventricular response. Here, another example. You can see here clearly F low case waves and completely irregular response. RR interval are irregulars. And as an example, uppercase wave F from atrial flutter means high amplitude. And low case F wave from atrial fibrillation means low amplitude. Beside this, flutter, the RR intervals are regular. And in atrial fibrillation, RR interval are completely irregular. There is only one exception for clinical cardiologists. If the patient has Venkeman block, flutter could be irregular as well. And now we will share with you malignant arrhythmia. It's called ventricular tachycardia. Of course, the stimulus originated from ventricles. The hallmark is QRS more than 120 milliseconds without P. This arrhythmia could be monomorphic, polymorphic, and the pattern could be left bundle branch block or right bundle branch block. Depends on a couple of characteristics. When we have twist in morphology, we call this arrhythmia torsade de points. And sometimes when the patient has no structural heart disease, we call it idiopathic ventricular tachycardia. Here, I'm showing you one example of monomorphic ventricular tachycardia. The QRS is more than 120 milliseconds, and there is a partner of monomorphic. Besides this, in this ECG, you can see one time more QRS wide, but the polymorphic ventricular tachycardia. Here, I do not want that you know this in details because it's a cardiologist's job. However, when you are facing a tachycardia with wide QRS, you are challenging to identify if this tachycardia is supraventricular with aberrant conduction or if you are facing a ventricular tachycardia. Why? Because in the first example, I'm talking about a supraventricular tachycardia, it's a benign arrhythmia. However, in the second example, ventricular tachycardia, it's a malignant arrhythmia you should identify. So, to differentiate it, there are a couple of criteria. One of them is called Brugada's criteria. And here we have the answer. In the next course, we can approach each in details. We have some details to find a flow chart to identify that tachycardia with wide QRS is ventricular or supraventricular tachycardia. Only to know that there is this detail. And what about the ventricular fibrillation? In this arrhythmia, there is an irregularity in electrical waves that underline ventricular excitation. Wow, more than 500 excitation per minute, which is the reflex on ECG. The ventricular complex changing in frequency, contour, and morphology. Here, you can see two examples: high amplitude ventricular fibrillation and low amplitude ventricular fibrillation. It is an emergency, of course, you have to shock the patients. In the same way, if in some cases you have ventricular tachycardia without pulse or with instability, we have to shock the patient as well. We call it sustained ventricular tachycardia when it takes more than 30 seconds or it leads to instability. It's called sustained ventricular tachycardia. Now, I'm showing you the pacemaker hitman. What means? Look at vertical signs. This kind of hitman is characterized by vertical signs. It means the electrical activity of the pacemaker. In this example, only one, because it is unipolar, placed into the ventricle. If the lead is in the right ventricle, the morphology is of left branch block. If the lead is placed in the left ventricle, the morphology is the right bundle branch block. Sometimes we have two vertical signs when the pacemaker is bicameral, and sometimes when it is associated with resynchronization therapy, the QRS is not wide. Thanks, my dear friends.
Thank you very much, Dinaldo, for this excellent presentation. Dear friends, if you have questions about presentation, if you want to ask something about the rhythm and arrhythmias, you can write to chat box, or if you wish, you can open your microphone and comment. There is one question about the junctional rhythm and coronary sinus rhythm. How we can differentiate the junctional rhythm and coronary sinus rhythm. If you wish, I can explain too for that question. You mean the coronary sinus rhythm is low atrial rhythm, and this rhythm is like the junctional rhythm, also the negative P waves on the D2 and the D3 and AVF, and so the only difference might be the PR interval. If it is low atrial rhythm, then PR interval is longer, and if it is more junctional, then the PR interval is shorter. And there is one question: how to calculate the rate in atrial fibrillation. We couldn't hear you, Dinaldo. Yeah, I think it's about the some technical problems. So in atrial fibrillation, we need to average the heart rate. Usually we take the 10-second in the ECG, and then we calculate the heart rate according to this. We count the R waves and calculate according to 10 seconds. And then a question more? I think Dinaldo left and he will come again. So there is just one question, and I replied it, and I answered it, but we couldn't hear you well. Yeah. Israel asked one question. What is the difference? Yeah, Dinaldo, I couldn't hear you. I couldn't hear you. Israel asked one question. What is the difference between the accelerated idioventricular tachycardia and AV nodal reentrant tachycardia? The AV nodal reentrant tachycardia is one type of the supraventricular tachycardia. It's the most common type of the supraventricular tachycardia. Let me show you one example from the ECG book. Now I will share my screen. Yeah, this is atrioventricular nodal reentrant tachycardia. Can you see my screen? Chietza, can you see my screen? Yeah, okay. Yes, so as we can see, this is an QRS, and the heart rate is around 180. And also we can see the pseudo R and pseudo S. This is typical for the atrioventricular nodal reentrant tachycardia. It's the most common type of the supraventricular tachycardia. And in case of the accelerated idioventricular rhythm, now I'll show that one also. As you can see, this is like a slow VT. Of course, it's not slow VT, but it is like a wide complex QRS, and the heart rate is usually between the 40 to 120. We can see the accelerated idioventricular rhythm usually as a reperfusion arrhythmias. This is a typical example of reperfusion arrhythmias. And now I will share my screen. There are two types of the idioventricular rhythm. The usual idioventricular rhythm is if the rate is between 20 and 40. Here we can see on the B, you can see on the right side below B, this is typical idioventricular rhythm, and the heart rate is around like 20 and 40. But if it is a little bit faster, like above the 40 until to 120, then we tell that it is accelerated idioventricular rhythm. Any comment from our presenters for any presentation that you want to point out some important part or anything? Ümit, Özge, Cengiz, Alper. Mehriban is also very experienced cardiologist.
Oh, thank you, Sercan.
Yeah. Yeah, Dinaldo is arriving.
I don't have any questions, but I would like to thank both of you. That was very comprehensive and good presentation. It was very educative. Thank you.
You are welcome. Thanks for your help. He will have very interesting lecture tomorrow with Cengiz.
Yes, yes. We are waiting everybody for tomorrow ECG Globe.
Dinaldo, can you hear us?
Yes, Sercan. I changed the computer. Are you hear me?
Yes. There are some questions, and I replied during this connection problem. They asked how we calculate the heart rate in atrial fibrillation, and I talk about the average in the heart rate. And there is one question about the AVNRT and the accelerated idioventricular rhythm. I told that one is narrow QRS, is like supraventricular tachycardia. The other one is the wide QRS, like 40 to 120. And these are the questions. And we will send the books to each participant. So no more questions. And I also don't have any questions.
Thanks. Okay, thank you for this action. Reply me because I changed the computer. I was using the MacBook Air from my daughter. I changed to my computer. I don't know what's happened, but I agree with you. Thanks. And thanks for everybody to your comprehension.
Yeah. You are welcome. So I think we can close this session. Let's open the camera and wave our hands. I think we need to wait a little bit.
Waiting, everybody.
Yeah. Okay, Chietza, I think you should close today's session. Then we will follow you.
Okay, thanks so much, everyone. So we'll meet tomorrow at, what's the time tomorrow, Dr. Sercan?
At 10 a.m. in Central European time.
Okay, so for us in Zimbabwe, it's 11. Let's be on time. Thanks so much, everyone. See you tomorrow.
See you tomorrow.
Thanks, everybody.
Thanks.
Bye.